Hello, everyone. Welcome to another episode of Mind Movers, where we're joined by Dr. Philippa Kaye, who is a GP, author, and menopause expert. She has been an incredible force within the medical community. And I just want to say, I actually met her when I got asked to be on the Piers Morgan show. And I was like, oh, she's just incredible. You know, I was being ripped apart by Piers Morgan, but no, not by Piers Morgan. Who was it then? Jeremy Kyle. And Philippa was amazing. What I have found extremely interesting recently is that Philippa has released a book specifically on menopause. I have reached out to her as well regarding my own questions with PMDD, mental health, fertility, and so forth. From mood swings to brain fog, Dr. Philippa unpacks the physiological and psychological changes that women face during menopause and how society's silence around the topic can leave women feeling extremely overwhelmed and isolated. So today we're going to explore the strategies to support mental health, challenge the stigma, and empower women to take charge of their health during this transformative time. So welcome, Philippa.
Seems like quite a challenge in a podcast, but let's go.
Yes, I love that so much. You know what, Philippa? I like people to really meet the person in front of me first and foremost. So I want to know a little bit about you. Where did you grow up? Where did you go to university and why did you choose to become a doctor?
So I'm a cliche. I grew up in Northwest London. I went to medical school in Cambridge and then in King's College London. But there is one question at medical school interviews that you're not supposed to answer, which is, well, you're supposed to answer it, but not the way that you want to. And the question is, why do you want to be a doctor? And what everybody wants to say is, because I want to help people. And for some reason, that's not supposed to be what the answer is. I think that's a really good answer, like a really good reason. But apparently that's not supposed to be what you say. But I did. I always wanted to be a doctor. I always wanted to help people. There was a very brief moment in time, apparently in nursery, where I thought I was going to be a ballerina. But by the time I was 4 or 5, I was set. And media medicine is a little branch out of that. But in my average day, I might see 30 patients. I might have 60 patient contacts. But I can reach thousands and tens of thousands and sometimes millions of people on a show on ITV or on Sky News or wherever it might be. And I think that there is a really important role to that part of medicine, because there is no point in us writing articles in a medical journal like The Lancet. Got to go where the people are. And sometimes the people are reading the newspaper and sometimes they're watching This Morning. And actually everybody needs that health information in a really understandable way. And so that's what we do. And inherently, I think I'm really nosy. And as a GP, I get to be really nosy and actually go inside people's houses and be nosy. And that are the two bits that I think make a good doctor: to be nosy about you and want to know you and who you are and what makes you you, because that feeds into everything that happens to your body, and being able to communicate with you and translate the medicalese into English.
So obviously you wanted to be a doctor since you were young. I mean, that would say the same with me in dentistry. Did you find medical school enjoyable, challenging, or both?
So I am the only medic in my family. And I remember really clearly some people being like, well, you've got no clue what you're getting into. And other people being like, well, you must really want to do it. I loved school. I'm sorry, I know so many people hate it. I loved it, and I loved medical school, and I still sometimes, so all doctors and dentists I'm sure have to do continual professional development. We have to keep learning because medicine didn't stay still when I qualified in 2004. And I go to these lectures and I think, God, the body's fascinating, like, wow. And I still get that sort of light up moment where I think, this is really interesting, this is where I want to be. And I really appreciate how lucky I am to have that vocation. And I see so many people struggle. And I think that to have a vocation is a really special thing. And then we get to use that. And so in some ways, and again, cliche, sounds really boring, but when your work is your passion, it's okay.
Totally. So The funny thing is that I'm opposite to you. Everyone in my family is pretty much doctor or dentist on my dad's side, typical kind of immigrant generation stuff. But I didn't want to be a doctor. And one of the big reasons for me is because, and now with my diagnosis of ADD, it kind of makes sense. It was all a bit too broad for me. So I went to broad.
Right.
So when I went to, I did this thing, I cannot remember what it's called. I was trying to tell someone, Nottingham University did it before you'd apply to do medicine, and you do this kind of weekend where you're a pretend doctor and they wake you up at like 2 a.m. and you don't know when it's going to happen, and you rush to this like fake A&E, and it's all very dramatic. And I remember also sitting pretending to be a doctor, and then a patient comes in with all these symptoms and you're meant to semi-diagnose. And I found the whole thing quite overwhelming because it was so broad. And as you know, with ADD, when you find something you really like, you tend to want to hone in on it. And although, exactly. And I feel like dentistry gives you the opportunity to hyper-focus much early on because you are just dealing with the mouth. Although elements of the training deal with medicine and you've got that part of it, I think the honing in on the teeth, the gums, the mouth, etc., and using your hands almost immediately in second year really helped me. I hated dental school, and the reason why I hated dental school is because I didn't really get on with the dentists, if I'm honest with you. I'm a natural creative, so I did English and philosophy, chemistry and biology,
right?
And the teachers were like, she needs to go to Oxbridge and do PPE, and then I was like, oh, but I want to be a dentist. So there was this kind of dichotomy that was going on within me that was like, where do I go? And I found myself naturally gravitating towards the people in the arts, the people that did English, the people that did politics, etc. So that's what I think that I found challenging, and the studying I did find challenging.
So I think that I find it really fascinating that dentists do the beginning of medical school, right?
Yeah.
I know how many teeth there are. That's about it, right? So they do like 2 years worth of medical school, and we know how to count teeth. That's it. So it seems amazing to me that you have all of this knowledge and then in one area. And I think that when a patient walks in the door in general practice, you have the whole of medicine open in your head, right? And then they ask you, they sit down, how can I help you today? And in fact, you're not even supposed to say that. You're supposed to just have the silence and let them bring something in. And then you sort of have to turn in your head to the chapter on orthopedics or gynecology or whatever it may be. And as you ask the questions, you're getting narrower and narrower and narrower. But when you do your medical school training and you do a bit of this and a bit of that, I went around and I thought I could see myself in this job and I could see myself in this job. And the only job I couldn't see myself in was actually orthopedics. I don't want to stand and hold a leg all day. And general practice gives me the opportunity to do all of those things, and you can make your job what you want it to be. So, for example, fitting coils or implants or something that's a little bit more practical. But for some people, they do have that opportunity to say, I want to do microbiology, but microbiology and only of viruses and only of this kind of viruses, and they can drill down. But I think I'd get bored.
So do you think that's why you were drawn to general practice as a GP, because it allowed you to have that spectrum, where you could dip into all various parts of medicine?
I think it's a combination of things. I think that's the first bit, and that's the biggest pull. And in particular, I really enjoy women's health, children's health and sexual health. And whilst they sound like they're linked, in the hospital they're not.
Of course.
And so I could do all of those things. But when I was in medical school, if you'd have asked me, I would have said I wanted to be a premature babies doctor, a neonatal paediatrician. And I loved that job.
Yeah.
And you really saw what you were doing and felt what you were doing in that job. And I went looking for female mentors. And I'm 45, which is not that old, but actually the world of medicine has changed quite a lot in terms of helping women be less than full-time and have babies and understand that that's part of the career. And I couldn't find a mentor that had what I also wanted, which was to be married and have lots of kids. And I could see people that did one thing or another thing or tried to do both, and how difficult it was. And I thought, I'm not sure that I want to do this. So let me create my way within general practice that I can do as much as I want of this bit I mean, obviously not neonatal peds, but you see loads and loads of children. About a quarter of our work is children. And so the two things together made me go for that. And occasionally people will say, oh, you're just a GP. Do you ever want to go back to hospital medicine? And we always say there's no such thing as just a GP. That's a specialty in itself. We are specialists in general practice. It's not the same. It's different. No, I don't want to go back to hospital medicine. I really think that this is the best choice for me to be able to do all the bits that I want to do.
Yeah, it's funny as well because, again, a lot of things that were drilled into me as a teenager about dentistry when I looked into it was that it's much more suited to a woman because of the hours, because of the flexibility, because of the fact that it's generally, unless you are in hospital, which very few people are, it's a 9-to-5 job. You can take time off, you can be flexible, you can do more private. And whilst there are so many females, it's a female-dominated industry, dentistry, still women are not at the forefront in the top position. So what I mean by that is people go, yeah, but there's so many female dentists. Okay, but where's the ones that are part of the boards, you know, of the big organisations? Where are the ones that are at the forefront of the lecture stages? Where are the ones that are part of the decision making and the committees? You know, you see so few of it. And whilst a few people may come along, I think there's still a degree of misogyny and a little bit of misrepresentation, to be honest with you. And again, a lot of female dentists will go off and do kind of aesthetics, and, you know, very few will become implant surgeons or surgeons in general. And I challenge that quite a lot within my industry. I mean, quite famously, there was a big online conference in Instagram was at its embryonic stages, and I remember there was all the big amazing male dentists holding this conference, and they sent me an invite, and I go, that's great, but you don't have a single female on the panel. And I think I got like a sort of bot reply or something, and one of the guys on the panel I knew quite well. He's one of the most respected dentists in the world, and the guys in the group chat sort of made fun of my message, you know, like, oh, look, you know, and he said, no, she's right. You know, women should be at the forefront. Women should be part of the decision making. And this is a global issue anyways, as we know. But I do find it interesting because, as I said, a lot of women had chosen dentistry as well because of the flexibility of lifestyle. What I do want to ask you as well, which I know will feed into, you know, the bulk of our conversation, do you think that medical misogyny is still a big problem?
Yeah.
And for those people that don't know, can you define it? What do we mean by medical misogyny?
So I think there's two things here. I think there's misogyny, which actually means a hatred of women. And that's not sort of how people use it in speak, but it means a hatred of women. And then there's medical sexism. And we have to remember that women have been around for millennia, and for millennia, we have been judged on what we look like and our ability to bear children. When you think about the big changes in sort of women's health that link with women's place in society, those are the Abortion Act in the 60s, the pill in the 60s, HRT, you know, whilst it was discovered earlier, didn't really come to the fore to the 60s. That's less than a century ago. So these are the things which were really a game changer for women. The pill separates women from having sex and necessarily having children, and all of that entails. And 60 years worth of something is not the same as 5 millennia worth of something, right? And so these changes take a huge amount of time. Women weren't mandated to be in medical trials until towards the end of the last century. That means that you could have any trial on a drug, on a condition, and not include women in it because the little darlings are too complicated with those periods, and, you know, and they might be pregnant. Yeah, we're different. Sometimes it's complicated. That doesn't mean that you exclude us. And so some of what we might call medical sexism or medical misogyny is about a lack of knowledge. So when I went to medical school and learned about heart attacks and the image of an overweight man in his 60s with a fag in one hand, clutching his chest with the other, and sweat dripping down his face, right? And actually women might present feeling a little tired or dizzy or with backache. And that was never taught. Now, some of the reason why that was never taught was because it wasn't known. And so I don't think that is misogynistic. I don't think that comes from a place of hatred or sort of a deliberate trying to hurt women. That comes from a place of a lack of knowledge. And so that bit needs to change. But we know really clearly that the gender health gap is real and the gender pain gap is real, never mind things like the gender orgasm gap. So the gender pain gap is, for example, that women's pain is less likely to be taken seriously than men's. You are less likely to get painkillers in A&E. And there is this idea in society that to be a woman is to live with pain, that periods might hurt and that having a baby might hurt, and that you just have to put up with it and continue in the Tampax advert with your roller skates on, plus managing your kids, plus managing your work, plus. And actually, to be a woman doesn't have to mean that you have to live with pain. And that message needs to feed down not just to women and society, but also to medicine. And what we're taught in medicine and how we challenge that. And often in the menopause space, in the menopause campaigning space, I'm asked, don't I get frustrated about how slow things are? And I say, well, one, we're fighting these millennia and that takes time. But two, that people have to understand where we are in the process. In order for your doctor to do something different, the guidelines have to change. In order for the guidelines to change, we need to show that there is evidence that the guidelines need to change. In order to produce that evidence, we need to do the trials. In order to do the trials, you have to fund the trials. In order to get the funding for the trials, we have to be aware that there is an issue. That's where we are. Raising awareness of an issue. That is the point where we are at. Raising awareness of, for example, testosterone use in women in menopause, and the studies are being done, right? And so these things take a lot of time. And in the meantime, we have to continue to advocate for ourselves over and over again.
Yeah, because forgive me, I cannot remember her name, but the very famous BBC TV presenter, because she came out, the one with the short hair, she came out
endometriosis, Naga.
Yes, exactly. And I think it was really interesting because I think she felt really gaslit as well, because her pain was really real and her symptoms were really real, and like you said, she was almost fobbed off. This is normal, this is just pain, it's part of being a woman, deal with it. A controversial question. Do you think that if it was men that were experiencing the symptoms that we had periods and all that stuff, that more funding would go behind the research needed to help the situation, the circumstances and the symptoms?
How many medications are available over the counter for erectile dysfunction? They've been available over the counter for quite a long time, haven't they? Research happens for things that people think are important. And as I said, they're raising awareness. Now, if the people making the decisions are men, they're going to potentially, or at least previously, think about issues that affect men. And for a long time, there was this idea that women are essentially little men. And we're not. So it's not that we are shorter and way less. It's the fact that estrogen, progesterone, testosterone, all genders have all those sex hormones, but that estrogen affects all parts of your body, not just your womb and your breasts. And that impact affects your brain, and it affects your joints, and it affects your bones. And so we need to look at women in the context of that, as opposed to thinking, well, they're just the same as men. They're not. And when we saw that, for example, really clearly in COVID, why were women doing better than men after the menopause? What was it? And there is this idea that sex hormones are about your reproductive system. They're much more than that. They affect every part of you, from the hair on your head to the skin on your feet. And so too for men. And I don't think, maybe I'm naive, but I don't think that these things are necessarily done malevolently. I think there's just this is what I was taught, this is what I know, don't know. And I think that there is a real difficulty that both medics and society have with saying, we just don't know. And one of the most difficult conversations you have with a patient is, I can see you're suffering and we can't find what the thing is to do about it. I can't find it on a blood test. I can't find it on a scan. That doesn't mean that whatever is happening to you isn't real. Endometriosis is a particular condition. The average length of diagnosis is 8 years. And for people who don't know, that's when there is tissue similar to the lining of the womb is deposited on other parts of the body. And so whilst the lining of the womb builds up every month and you have your period, that comes out through the vagina, and the blood and the womb lining goes. If that tissue is on the outside of your womb or on your bowel, for example, when you bleed, you're bleeding internally and there's nowhere for that to go. And that causes inflammation and scar tissue, which cause all the symptoms. Not seen on a blood test. Now there are more specialist scans, but often not seen on a scan at all. And the gold standard of diagnosis is with keyhole surgery. And that you're not going to necessarily do for everybody who comes in with symptoms initially. And so the time to diagnosis is long for all kinds of reasons. But it starts with this idea of, period pain's normal. No, it's not. For anybody listening, if you can't get off the toilet for 3 days because you're bleeding so heavily, if you're missing school or work because you're bleeding so heavily or you are in pain, go to the doctor. We will do something about it.
I don't know if this was just a rumour. I also saw a clip on social media, as you do, that claimed that the word hysteria is related to hysterectomy and the symptoms that a woman had from a mental health point of view.
Yeah.
Is there truth to that? I want you to unpack that a little bit for me.
So it comes from a Greek word, and hysteros, and it was thought that hysteria was due to the wandering womb. And in the 19th century, if you were a bit difficult, maybe you were a bit mouthy, maybe you were irritable, maybe you had anxiety, the treatment was electrical stimulation of your clitoris by a medical professional. Yeah. So, orgasms might have helped, who knows? They're good for all kinds of things. But women's sexual pleasure was so not thought of that this was a medical treatment for the wandering womb.
And was a hysterectomy the solution towards at all?
So a hysterectomy means removal of the womb.
How did that come
So this
up?
is history of medicine. I'm not sure if that was used as a treatment, but that hysterectomy was much more common than it used to be much more common than it is now. Because if you had, for example, in very, very heavy periods, and we didn't have things like a coil or the pill, then a hysterectomy would have been solved the problem because you remove the womb. Okay, well, you're not having bleeding anymore. So hysterectomies aren't as common as they used to be. I don't know their history around that. It would be interesting to find out.
But the word hysterical has not necessarily got a positive connotation. No. And so the fact that even like a hysterectomy, hysterical, like we should be challenging language in the same way language is being challenged in lots of different ways with regards to gender. I think it's really important that we give that consideration.
So there is a link automatically between the word hysterical, which is not the same as mentally unwell, and you don't really describe men as hysterical.
Yeah, exactly.
It's a derogatory word aimed at women, and the basis of that word is because you got a womb.
Yeah, it's really interesting. Now, one thing that really resonated that you just said, that is sometimes we have patients, and we certainly get this in dentistry as well, where they have symptoms and you cannot provide necessarily a solution. In dental school, it was described as either having phantom symptoms or, there was always a link perhaps to something mental health. As I progressed further onto my career, I started to read the work of what I considered to be more progressive doctors. And my father would argue, who was a more old school doctor, it's a little bit woo-woo. And the reason why I say woo-woo, because in his mind, it's not necessarily tangible. So for example, I read the work of Dr. Gabor Mate, the work of Dr. Bessel, the body keeps the score. And I think that there's a real gap within medicine and dentistry that does not allow and give space to recognize that certain emotions, traumas, and past behaviors can certainly contribute to the symptoms that we get and manifest physically. What's your thoughts on that?
We know that the brain and the body talk to each other. We're not quite sure how they do it, but we know that they do. And And actually, everybody can think of an example of that. You have a bad cold and you just feel a bit bleh, and you don't feel happy and you don't feel energized, right? And when you're in pain, that your mood drops. So these are examples that people sort of think, well, yeah, or your libido drops. Why would you want to have sex? And so we know really clearly that physical conditions can have mental health symptoms, and that psychological conditions, and by that I don't mean made up, I mean related to your mental health, can have physical symptoms. So in depression, that might affect your sleep, it might affect your energy, it might affect your appetite, and in really severe depression, it can even affect how quickly you speak or how quickly you move. Someone with anxiety, if you watch someone with severe anxiety who is shaking and fidgeting and their heart is racing and they've got palpitations and chest pain and shortness of breath and they feel sick. So we know really clearly that the two interact. We also know that your gut is what we sometimes call your second brain. Your gut produces serotonin, same as the brain, and it responds to serotonin. Actually, really interesting in regards to women's health, there are bacteria that are involved in the production of estrogen and the response to estrogen. It's called the estroblome. And so we know they talk to each other. We know that if you give patients with irritable bowel syndrome an SSRI antidepressant, doesn't mean they're depressed, but it makes their symptoms better. We know that we can use antidepressants for all kinds of things which aren't depression. So there is a definite link between the two. I think there's a struggle in two ways. One is with the doctor saying, there is nothing more I can do in terms of medicine, which is hard for us to say when we want to make you better. And actually, I think as GPs, often we're better at that than hospital doctors sometimes, because we see things from a different angle. So as a GP, I'm ruling stuff out most of the time. And then as a hospital doctor, a GP has already said to you, there's a problem here. I might not know what it is. Go find it, right? So they're ruling stuff in. And we know you, we know your family often, we know where you live, we know what you do. It sounds really creepy. But
Stalker.
we know about you. And sometimes we're having these conversations where we say, I see that you are struggling, but there isn't necessarily a medicine to fix that. So now what are we going to do? And actually the answer often in those situations is around talking therapies. And that's where the second barrier comes in, which is the patients often say, you're saying I'm crazy, I'm making it up. And I'm not saying that. What I'm saying is there isn't a medicine to help. So what we now need is some kind of therapy to help you manage what you have. And so if you go into a chronic pain clinic, you will have a consultant anaesthetist probably who will be talking about medicines and sometimes epidurals and all kinds of things. And you'll also have a chronic pain psychologist, because not everything in medicine is answerable.
Exactly.
And that doesn't mean that we can't help you in some way. The help might be different. And there is a lot of evidence that for certain symptoms and conditions, that often they will be related to what are really clinically called adverse childhood events, and what are less clinically called often horrible stories of abuse and things like that. And I think that we have to be really open to talking and thinking about those things. But I think that it requires a mind shift in both the doctor and the patient to be able to say, this is where we are. And the reason why that's so hard often is because we got to start with, well, maybe your thyroid's just low, because I can fix that with a tiny tablet. And so you have to go down one route before you get there. And that's really difficult for everyone.
What's your thoughts as well? Because again, going back to sort of the more progressive doctors that look into that, and I know that the NHS is integrating that, and there's huge amounts of research. I talk about this a lot on my podcast. Integrated psychedelic therapy. So I know that, for example, some places are offering, not in the UK necessarily, but in Switzerland, they're doing a lot of research around mushrooms. They are also, I understand, my friend had a ketamine drip, for her depression on the NHS, which I'd never heard of. That part of medicine is completely new, but looking at the history, because I'd read a great book, How to Change Your Mind, which goes into the history of psychedelic medicine. These medications were actually making huge amounts of progress back in the day. Then Nixon comes into power, war on drugs comes in, hippies, love and light. I don't want to go to the Vietnam War. It's all quite interesting, but then when I look at the psychiatric implications, these medications were used for PTSD, people that were going to war, marriage counseling, all those different things. Do you think any of those medications will actually make headway? And for the ones that are being used, like ketamine, do you think there is benefit, or, what's your views?
Let's start with I do not recommend that people take illegal recreational drugs with the idea that it's going to help you medically. That is not what's being talked about. Microdosing under medical supervision. They're two very separate things. And actually, medicine is really interesting because we use illegal drugs in a legal way a lot of the time. So medication for ADHD is a controlled drug because essentially they're stimulants. We use opioids if you have an operation, if you have, a spinal anaesthetic, if you're having a cesarean section, we use them at end of life. And they can all be abused and misused in different ways. And so there's often been a crossover. And what we need here is more research. And what seems to be the case is that there are lots of people doing things sort of on their own, saying, well, I just get this from my friend around the corner. That's not the same as what we're talking about. And I think that we just need to know more. Another example is using magnetic stimulation of the brain.
RTMS?
Yeah, transcranial magnetic stimulation. And for a long time, a treatment for very severe depression was ECT, electric convulsive therapy. And when I did psychiatry, when I was a psychiatric SHO, it is still used. Was something that was used, is still used. Not in a one flew over the cuckoo's nest way. People are given an anaesthetic, it's not the same. And actually, for people with very severe catatonic depression, it can work. And now there are forms which is sort of, you might consider it almost like ECT light. And now they're talking about magnetic stimulation. And all of this, to me, is entirely fascinating. And we need more research because what we've got are vulnerable people. And whenever any of us is unwell in whatever way we are unwell, and I say this as a patient who's had cancer myself, we are vulnerable to the snake oil because we want to be better. And where medicine doesn't have the answers in easy terms, in a pill, right? Because often answers are hard if they involve doing more exercise and eating a certain way, etc., etc. That's much harder than please take this tablet 3 times a day. Where medicine doesn't have the answers and other people make huge claims about what it is that their product, their supplement, their course, their whatever can do, we want it to work so desperately that we're vulnerable to it. And I think that actually we need to do good research, which is not quite the same as research. We need to do good research, find out more to protect the people, because there are an awful lot of people out there selling an awful lot of stuff for an awful lot of money.
Yeah, because it's interesting, because as I said to you, like LSC has a dedicated psychedelic research centre, which is super interesting. So I'd love to see. But as you said, unfortunately, the problem is where the abuse comes in, where people take these to self-soothe in a way that without doing the work, and I think that where it becomes more of an interesting is, when you see the research centres in Switzerland where you have a 70-year-old patient with cancer that then has therapy alongside some of these treatments. And I think that's the only way it can really sort of move forward, as you said, with good research. Yeah. You mentioned that you had cancer. So let's talk a little bit about that. How old were you when you got diagnosed? What were your symptoms?
So I was 39 and I didn't have the classic symptoms. I had bowel cancer, I call it the shit cancer. It doesn't have great PR, bowel cancer, because it's brown. And people don't like talking about it. I had 3 emergency cesarean sections and my appendix out, and an ectopic pregnancy, actually. So I'd had a lot of pelvic surgery. And after the birth of my youngest, who is now 9, I had some pain in my skull and thought, well, you've got a lot of scar tissue down there. All right. And managed it for a period of time. And then a few years later, actually, I had much worse pain, but not constant. I didn't have a change in my bowel habit. Everyone has a bowel habit. You might go to the toilet once a day. You might go to the toilet twice a week, 6 times a day, whatever. Your normal is your normal. And if that changes for more than 3 weeks, your doctor wants to know about it. I didn't have that. I didn't have blood in my poo. I didn't lose weight. Wasn't tired. Nothing. I just had this pain sometimes before I went to do a poo. And it began to hurt more. And I went to my GP and I said, what do you think is going on? I think it's related to scar tissue. And she went, well, yeah, it's got to be. Let's go and see a gynecologist. And I went to see a gynecologist who said, I think your womb is stuck to your bowel, which happens from scar tissue. And I'm going to need a bowel surgeon in there with me. So I think you should go and see a bowel surgeon first. So I went to the bowel surgeon who went, well, we better just be careful and do a scope. And I remember thinking really clearly, well, that's annoying. Because I don't want to take a day off work and do the bowel prep and be on the toilet all day and then have to take another day off work and have someone shove a camera up my bum. But I was like, well, all right. And I remember that they pushed the drugs into my arm and I lay down and thought, okay, and there's a screen there for the surgeon to see and I can't help myself. So I looked at the screen and he put the camera in and then I saw my cancer because it was 8 centimetres up. No, sorry, it was 12 centimetres up. They left me with 8 centimetres of rectum. And I turned my head and I looked at the surgeon and as his eyes came up, I thought, oh, that's it. The world changes today. And I remember really clearly what happened next, which was he couldn't get past the tumour. It was too big. And he said, and it was hurting. And I said, you have to do what you have to do. Don't worry about it. And he was like, no, we're going to go and do a CT colon a different way, which is essentially where they then fill your bowel up. And then they take like an X-ray scan, a CT scan of it. And he said, but first I need to give you a tattoo. Now, I'm a good Jewish girl, and my parents would never have let me have a tattoo. And my mum was waiting outside to pick me up. And I said to him, what do you mean? My mum's going to be furious. And he said, I have to tattoo your tumour from the inside so that when I go and get it from the outside, if it hasn't gone through the wall, it had, but he didn't know that at the time, I won't be able to see it. So I need to tattoo it. So he put the tattoo in and he said, and they sort of sorted everything out. And he said, I'm going to be right behind you. They're wheeling you back to the bay. I'm coming to talk to you. My mum was there before me, before he was. And I turned to my mum. And actually, I was 39. I had 3 kids and a husband. Never occurred to me I was going to tell my mum that I had cancer. And I turned around to my mum and she could see that I'd been crying. And she said, what's the matter? Did it hurt? And I said, Mummy, I've got cancer and a tattoo. I'm so sorry.
Yeah.
And that was my primary thought at that exact moment. Obviously, that then passed and that was no longer my primary thought. But for a while, I focused on that bit.
And so then what was the treatment? So what did they decide that was the best port of call?
So then it was all really quick. And I had a large part of my bowel removed a week later. So where it was, they took a few centimetres below, but they took lots above. And that's a really big operation. And there's a possibility that you might have a stoma bag, which I didn't. And your bowel does not like being touched, does not like it. And it needs to heal and rest, but it might go on strike for a bit too. And you have to learn to eat again. You go through a period of time of nothing at all, and then 30 mils of fluid an hour of water, and then you work your way up, and then eventually you get to like a broth and then milk, and you work your way up to eating. And then I had 6 months worth of chemotherapy. And then they said, and now we think everything should be done. Let's just do a scan to check. And on that scan, they found more lesions.
Oh, no.
And we were then January, February 2020, just as COVID's coming. And they said, well, let's just hang on. Maybe it's one of those things. And by the time we got to April, there were many more lesions, and they said, well, we can't wait. We're going to need to do a really, really big operation. We need to take out, bearing in mind the first one was a whopper, we need to take out some of your small intestine and some of your muscles around your stomach and your back, and we might have to take out more large bowel, and we're going to put chemotherapy in and blah, blah, blah. And we're in lockdown, and they were talking about the recovery after that, and everybody's kids were at home and homeschooling, and I thought, I don't know how I'm going to do this. I don't know how I'm going to manage this. And they said, well, we're also not sure about putting you in hospital in this exact moment. And so they did a sort of like a mini surgery in the May time to try and hold things off. And by September, we were about to enter lockdown again, and they were like, you can't wait. And I was in hospital for 15 days. 10 of those days were in ICU on my own. And that is undoubtedly the hardest thing that I have ever done in my life. What it also taught me, though, is something that I did not know before. Genuinely, I did not know before, which is that I am enough. I can be enough for me. I can be strong enough for me. And you don't have to go in happy. You don't have to be toxically positive the entire time. You just have to keep stepping. And you can do that stompingly angry, but that is where your strength is. And that really has changed me to know that. And then after that, when they put the chemo directly into my pelvis, and they removed a whole bunch of stuff. And then that's when they said, we've got it all, and we think that you're cancer-free. And that was 2020. And since then, I have still had surgeries every year to try and fix the issues that the first surgeries produce. And every January, I don't make a New Year's resolution, I make a hope. And that hope is, please this year, let my cancer not come back, and let me not have a surgery.
Yeah.
I haven't made it yet. Hopefully this year will be the year.
Honestly, you're so amazing, and I feel every word, because both my parents had cancer a few years apart from each other, and I think it's so difficult. I've not been in that position, but having a parent in that position, weirdly, I was like, I'd rather have it than my parents. My dad is like my hero, so for me it was the most harrowing thing, and he was in surgery for like 13 hours, and I remember thinking he was dead, I'm going to be honest, because I was like, why haven't we heard from anyone? Why hasn't anyone updated me? And I had this huge panic attack, and he had a radical prostatectomy. Just everything removed, and that affected his lifestyle forever, because you've got problems of incontinence, you've got problems with so sex life gets affected, everything gets affected. So he's had to have multiple surgeries as well to try and rectify it. But
I think we know that 1 in 2 of us are going to have cancer at some point in our lives. That means everybody is going to be affected by it, because we're all going to know somebody with it, or have it, or have a work colleague, or whatever that may be.
Why? Why do you think the numbers have increased, even though our lifestyles are better?
So I think there's a number of, I'm going to come back to that. But I think that we are getting better at diagnosing cancer. We are getting better at treating cancer. And that means that more of us are either going to survive it or live with it.
Okay.
What we're not good at, because we're not good enough at getting people to come forward with the symptoms in the first place, and attendance at screening isn't high enough, and all of these things. But what we're really not good at is talking about survivorship and what you're left with. What are you left with if you live with a stoma, which can be life-changing and life-saving? What are you left with if you have low anterior resection syndrome because you've had most of your bowel removed and I can't wait for the toilet? What are you left with if you're put into a premature menopause, or that your brain is affected, or you have neuropathy and you can't feel your hands and feet, or right? And we don't talk about all of those things, and we need to do much better at those. Why do I think that more people are having cancer? I think there's a number of reasons here. There's 2 things. We know that cancer in young people is getting more common, and in particular actually around bowel cancer. And bowel cancer is a cancer where they think that there are a significant number of patients and cases that could be prevented from lifestyle. Now, mine was found out to be genetic. which in itself has implications, because when they gene tested me and they found the gene that they doubled my risk of bowel cancer. So there's the concern, not only is my cancer going to come back, but am I going to get a new bowel one because my genes haven't changed? But also it has implications for the rest of my family, right? Because if I'm a carrier, yes, I could be the first mutation, but maybe my siblings. What about my kids? And so you make a decision for yourself. Yes, I want to know because of the links with other cancers and various other things. But this knowledge then goes to other people as well. But we know, for example, that processed meat and red meat and alcohol and smoking and obesity and sedentary lifestyles, all of those things contribute to cancers. But we also have to remember that when we talk about 150 years ago, most people were likely to die either at birth or in the first couple of years of life. And if you're a woman and you made it past childhood, your next time that you're most likely to die was during childbirth, right? So, and then if you managed to get past that, then your life expectancy was sort of not so significantly lower. But when you then look at life expectancy overall in the Victorian times, you say, well, those numbers are much lower, we're living much longer. Are we? Yes, we are, but those numbers are skewed because so many people died in childbirth or at and around birth, that it means that the average, because this is how maths works, gets a lot younger. And so we are now, thankfully, more likely to survive childhood with vaccines and nutrition and clean water. We are now, thankfully, more likely to survive childbirth with good antenatal care and care on the labour wards, etc., which means that more of us are going to be hitting points where we can get these things. And we need to do better at prevention. And some things around prevention are not sexy and exciting, but they do work. We know, for example, that there is no safe amount of alcohol to drink. Well, no one wants to hear that. But that is true. Alcohol is a carcinogen. We know that physical activity decreases your risk of cancer. That's a bit boring, isn't it? People would prefer to do something else, but actually those are the things that would make a huge difference.
So lots of things to unpack. First of all, my partner says this all the time because he's reading a book on Alexandria. So I'm half Egyptian. I don't know if you knew that, but he's reading a book on Alexandria. He's really excited. We're going to Egypt. He's never been. And he's fascinated by Alexander the Great. And I talk about like the ancient Egyptians because the ancient Egyptians are super progressive in medicine, I'm sure you know. And I'm like, yeah, but no one really lived that long. He was like, no, that's a misconception. He's like, because people, the time that we're going to die was in, you know, as he said, childbirth or when they were really young. And then actually lots of people were living till they were like 70 or whatever, but it's skewed numbers. So I love the fact that you've brought up that point. One thing that becomes apparent to me is, you know, for me, what really worries me as a society as a whole is that we want the easy way out. I once read something beautiful, an article by Mark Manson. He wrote the book, The Subtle Art of Not Giving a Fuck. I don't know if you read it, you know. And he wrote an amazing article about New Year's resolutions and happiness as a whole. And one thing that he brought up, which I really loved in the article that I read, is that if you ask most people what do they want in life, they will say, I just want to be happy. Okay, what does that look like? I just want a nice partner. I want to go on nice holidays. I want a job that I like. I want enough money to enjoy my life. I want great sex. They say all these things. He says, well, it's all very well saying that things, but the question that we really need to pose is, how much are you willing to suffer for what you want? So what I mean by that is you could say, I want to be a really successful doctor like Philippa, have a platform, be on TV, go into a work environment where I love treating patients, or I want to be like Rhona and have my own dental practice. But what they don't understand, do you want to do a 60-hour week at some point in your life? Do you want to sacrifice time with your friends and family or your social life? So when you start asking those questions, because usually there is so much that goes behind requiring the life that you want, most people don't want to do that. And that's the same, there's a similarity in what you said, because you said, are you willing not to drink alcohol? Are you willing to wake up early to exercise or go after work? Are you willing to make healthier choices? And most people want. That brings me on to a question that perhaps is going off onto another tangent. But with regards to health, either eating less and exercising more, the easy way out seems to be Ozempic or these weight limiting drugs. Now, they have their place, as we know, with people that actually need them. But what I'm seeing more and more, especially because I'm in the world of social media, where aesthetics and the way you look and dropping 2 or 3 kilos makes you look and feel better, is something that people are doing. And I have even models and influencers admitting to me in my practice that they're taking it. They're already a size 8. We're not talking about obese people. Now, do they live a healthy lifestyle? No, they party, they drink, they take drugs, etc., etc. So what is your view on the weight loss injections? Where do you think it's going? Is it being regulated? I'd love to know, because, and could it have a positive impact because it is limiting your ability to eat and drink alcohol, etc. So could there be a positive benefit?
Let me just answer the first bit, which is, I think that with regards to happiness, satisfaction is not quite the same as happiness. And I think that the answer to all of that is to be able to find the joy in the tiniest of things, to be able to find the joy in sitting under a tree and watching the sunlight through the leaves,
absolutely.
to be able to be present in any moment and actually find the peace within that. And to be satisfied and say, this is enough for right now. I have enough. And not to constantly be grasping for the next. And that, for me, is the answer to where happiness is. For me, that's not the same for everybody else. I think that weight loss drugs are saying something very interesting about society.
Yes.
Let's start with the fact that obesity is a chronic disease which is mostly genetic, with over 1,000 genes involved. Epigenetics is how your environment shapes your genes, and environment absolutely plays a role in whether or not these genes express. But we have been brought up in a society which has a huge amount of weight stigma. Every book you've ever read or film you've ever seen, the bully is a fat kid, a fat, stupid kid, right? When you look at a picture in the newspaper and you are looking at someone with obesity, they have a grumpy face. We are not shown, and that weight stigma means we have evidence to say that if you have obesity, you are less likely to have a front-facing job, to be a receptionist, to work in a shop, right? You are less likely to attend your screening programs. You are going to have worse mental health as well as physical health. The stigma about obesity is very real. And medicine and the government have not helped us, right? We put all the blame and the onus on these people when actually no one's telling the truth, which is losing weight is really hard.
Really hard.
Keeping that weight off is really hard when your metabolic set point and all of your hormones are fighting to maintain the weight that you have. And so these medications are an absolute game changer in the world of obesity and diabetes, when up until then, the only thing which has evidence for working is surgery, which is life-changing surgery, and now these medicines. There is not evidence for any diet in the long term. So people lose weight and they put it back on, often putting on a little bit more, and then they lose weight, and that yo-yo dieting has a real effect on the body. So we need to be honest with patients and say, I see you and it's hard and it's not your fault. Let's just start with that. And actually, when you do that with patients, they are almost so overwhelmed by that, because I am yet to meet a patient who has obesity who doesn't know that they have obesity, who hasn't tried absolutely everything that they can over the years, every diet, everything, because they are desperate to lose that weight. So let's be honest and say, I see you, it's really hard and society has not helped you at all. And these medicines have a huge place within that. And that access should be easier. There is also a risk for every medicine that we have, every choice that we make. When you cross the road, I need to cross. The benefit of crossing this road is I will be on the other side. The risk is a car might hit me, right? Everything that you do is a weighing up of the positives and the negatives. And when we are talking about obesity, the potential benefits of these medications are huge. And in those people, it might be worth the potential side effects, the nausea, the vomiting, the diarrhea, the abdominal pain, right? The being on them long term, all of those things. As your weight gets less and less and less and less and less, and now we're talking about someone with a healthy BMI, well, hang on, what's the benefit that I'm getting physiologically in my body in order to balance with these risks? Well, my risk-benefit ratio changes. And these medications are not licensed for use in people with a low BMI. And the potential for misuse is huge, and we are seeing it. We are seeing young girls going to A&E with severe abdominal pain. We are seeing young girls with eating disorders who are, standing on a scale with a bunch of rucksack with weights on their back in order to say, oh, but I am this weight. And there definitely needs to be regulation around misuse. That doesn't take it away from the huge group of people that need it. And then we need to separate the idea of weight from physical activity and health. Because I don't care what your size is, physical activity is beneficial. And so people who say, well, if you have overweight, if you have obesity, you should just move more, then you'll lose weight. No, you should just move more. Full stop. It's good for you.
But this is the thing, and it's just I'm going to get emotional about this, because I cannot tell you that, as a child, I was a pretty confident little girl, and I kind of love my body because, you don't come out of the womb hating your body. My mother was from a Middle Eastern background, with some European blood in her as well. We've got my great grandmother was German, and my mum was really tall. She was a model. She also had her own eating disorder. Went off and did nutrition. Kind of healed herself through that. But I think that there was always this fascination with the kind of tall, white, blonde, skinny person. And so, there were comments that were made from my parents, who typically, again, come from a Middle Eastern background, but desperately want to fit into this kind of European setting. I didn't care. And it wasn't until I went to university and all the girls who were boarding school girls who all had eating disorders. I never had an eating, because I went to school in Queen's College, you know London very well, multicultural. London is vast. I didn't have a problem. I am Middle Eastern. My body shape is Middle Eastern. Small top half, hips and bum. That was just a thing. And then everyone told me I was overweight, and then I got asked to do modelling, and then everyone was like, well, you can't. You're too big to go to this casting. And I was like, okay. So I developed an eating disorder, and the problem is that everything around me, of course, the media perpetuated an idea that I was big. Bridget Jones was deemed as being big. She was not big. She was 8 stone, I think, even, or 9 stone, and Bridget Jones, Britney Spears, the most talked about thing was when she put on weight. Special K diets, eat cereal once a day, So the idea that the smaller you are, the better you are was heavily ingrained. And unfortunately, as I dropped weight, people told me I looked better. And I think that I was sort of grateful for the Kardashians in a way. I don't really like them in general, because suddenly I was like, oh, having hips and bums is cool. Do you know what I mean? Suddenly I was okay to have, instead of being told to cover up that part of my body, I could go to the gym feeling okay. And now I'm seeing a regression again, that people are like, no, again, being waif thin and Kate Moss style. And I think that's where the danger I'm seeing. And I think, again, you're having celebrities endorsing their fitness program after losing 7 kilos in a week. Sorry, you're on Ozempic. It's obvious. No one loses 7 kilos.
And even if you're not on Ozempic, you have a personal trainer every day, and you have a
personalized
chef,
meals,
and you do not have to get 3 buses to work, and you don't live in a food desert where you have to get a bus to go to a supermarket, and you can only have what you can carry, and you can only afford what you can afford, and you're working 3 jobs, and you've got kids, and these are not, we're comparing apples and oranges. There are fashions and trends in everything with regards to women, from pubic hair to body size. What that means is you will never, ever, always be the ideal. And we need to learn to separate ourselves from that. And that is incredibly difficult. And as someone who's on the telly. The first time that I was asked to do a photo shoot for a magazine I was writing for, I went to this place, and the magazine brand also had one of those lads mags, and the studio was shooting a bikini shoot. And then me straight after. And I remember walking in, seeing a rack of bikinis, thinking, yo, I'm a doctor, no way. I'm literally here for like the shot of me at the top of my column.
Yeah.
What is going on? And somebody put makeup on my face, and somebody told me what to wear. And then an editor came over, looked at a still of my photo and said, she looks too young, make her look older. She looks like they won't take her seriously enough. And I remember thinking, in my job, no one has ever made a comment about what I look like, ever. And you step into this world where what you look like matters.
You say that, but I think I have been judged since I applied for dental school. And I say that because, look, I had a chat with one of my friends who's a journalist yesterday. And I was like, look, I really struggle because by nature, I've always loved colour. I've always loved getting dressed up. And I kind of got coined by the media as the glamorous dentist. And I just think that doesn't necessarily have a connotation of being taken seriousness. Yeah. And I think I remember as well, I was asked to do a big campaign for a big brand because I had endorsed their medical product so well because I truly believed in it. Patients loved it. They loved everything I was doing. And I turned up for the photo shoot and they were like, but can you tone down the face? I was wearing mascara. I'm like, this is my face. Literally, this is my face. My features are the way they are because I'm Middle Eastern and I can't tone it down. Even when I'm not wearing makeup.
But in the NHS, no one ever said, oh, you look a bit pale today, you did a night shift.
I hear you. But there was certainly, look, I went for my Bristol interview and I'll never forget it, and again, I think I wore a colourful suit and everything like that. And I think that they had made a comment that I probably wasn't suitable to become a dentist. And I didn't get into the dental school. And I went to my Leeds University completely dressed in the way that I wouldn't dress. I wore a really dowdy black suit. I scraped my hair back. And I just talked about the NHS essentially, and I got a place. But I knew that I was a fraud in a way because what I presented in the interview was what I knew they wanted to hear. And to a degree, perhaps in interviews and things like that, we need to do that. But I think throughout dental school, there was always these comments from people about the way that I look or about what I was wearing and so forth. Social media has given me the freedom to have expression. The one thing is that I have creative expression to be like, you know what, I am a bit glam, but I also know my stuff. I also love my patients. And I think, even the ability to show empathy is something that's challenged by colleagues. You're amazing at it. I talk about it all the time. I'm not afraid to cry on camera. You clearly aren't either. But I've had medical colleagues and go, but if a patient sees you like that online, they might think that you're not stable enough to treat them. I'm like, I disagree.
So I think that
it humanises you.
Yeah, patients like to see the human. But as doctors, we have to be very careful of how much you give.
Yeah.
Because if you give a little piece of yourself every single consultation 10 minutes apart, there is nothing left for you.
Yeah.
So in some ways, my strong lipstick is part of my armour.
Yeah.
Put it on and I am Dr. Kaye, right?
Yeah.
In some ways it does that. But I think that we would never be having this conversation if we were two men.
Yeah.
And as soon as you change the word women to men, if that feels weird, no, we wouldn't do that if we were two men. And maybe I'm generalising, there will be some. But, in general, then there's a sexism issue, right?
Yeah.
That we don't judge people in the same way. I have had patients stand at my door when I've opened my door and called a name and they've said, oh, but I wanted to see Dr. Kaye. I am Dr. Kaye? You don't look like Dr. Kaye. Oh, professional makeup artist didn't do my makeup this morning. Yeah. And I will sort of say jokingly, no, that's me, just not on breakfast TV this morning. Yeah. Oh. Yeah. You're like, let's talk about you, shall we?
Yeah.
People feel that they have a right to comment. I have 2 boys and a girl. When I had a girl, straight away, day one, oh, is she your princess? And my husband would say, no, she's our engineer. and people make comments about little girls in the way that they don't make comments about little boys. Don't you look pretty today? Haven't you got a nice dress on? Not, aren't you so strong? Look at you running. Look at what your body can do for you. You know, all of those things. And that messaging starts so young, and it's so ingrained, and it's actually really difficult for us to fight that constantly.
Yeah.
Because it is a constant. It's not like you can just feel good about yourself today and then it's all okay. These things are a constant battle. And then I think if you add something like menopause into the mix, where there are changes in your body, and suddenly you feel the weight of society saying, well, hang on, you're supposed to give us children and look good, and now you can't give us children, and, you know, you're a bit wrinkly and your boobs are saggy. And it's not a wonder that, aside from the physiological changes that are happening in your body and to your mind, that society puts a whole other pressure on you. And that is one of the reasons why I find women's health so fascinating, because you can't separate it from society and culture, and sometimes religion too.
So is that what drew you to writing your book about menopause?
So I wrote, my first book about menopause came out a few years ago, and that was purely born out of the need of the women that were walking through my door. And that was sort of 5-6 years ago that I was writing it, and it wasn't talked about at all. And there was such a knowledge gap. And whilst we may be better in some groups at talking about it, actually, when we went up and down the country on the This Morning menopause bus, the question I was asked more than any other was, what is the menopause? How am I going to know if I'm in it? So we think that we're writing about it and talking about it all the time, but actually often we aren't. Or that it's not getting to everybody. And so the reason that I wrote this book was because not everybody wants to read like an essay-based book. People learn in different ways, and I wanted something that was full of pictures and infographics and diagrams that made things really clear, but also that menopause is not a subject which is just for women in their 40s, that everybody needs to know about women's health.
So tell me as well, so what are the hormonal changes that happens during menopause?
Got to go back to GCSE biology just a little bit for people listening. The menstrual cycle is stimulated by hormones in your brain. Tells your ovaries, come on, I'd like you to mature an egg. The ovary produces estrogen, and then there will be a spike in a hormone in the brain. Out comes an egg, and the shell of that egg produces progesterone. And the egg travels down the fallopian tube, waiting for Mr. Sperm to come along and fertilise it, implant, be pregnant. And if there is no sperm, fertilization doesn't take place, then the hormone levels will begin to fall, and the egg and the lining of the womb will shed in your period, and we start again. But you are born with all the eggs you are ever going to have. And actually, to me, this is one of the most gobsmacking facts ever. The egg that you were made from was formed in your grandmother's womb, because the egg that you came from was formed when your mother was developing in your grandmother. And that's why if your grandmother drank, it can affect you. So you're born with all the eggs you're ever going to have. You lose lots of them even before puberty. And although only 1, sometimes 2 eggs mature each month, you actually lose about 1,000. And at some point they run out. And when they run out, the menstrual cycle is not going to restart again, and you go through the menopause. It literally means the last period. What that means is that your brain produces high levels of the hormones trying to kickstart it. It's like yelling at your ovaries, let's go. But the levels of estrogen and progesterone fall. And that is what causes the symptoms of the menopause. Now, we have a medical word for the day that you started your period. That's called menarche. Menopause means the last period. We can't tell that you've been through it generally until you haven't had a bleed for 12 months. After that point, there is no such thing as one last bleed. If you bleed after not having bled for 12 months, you must always go to the doctor. But just as starting your period was just one point during puberty, the lead up to that last period has lots of changes, and it's called the perimenopause. And you can have symptoms for years before that last period and for years afterwards. And those symptoms are not just related to your womb, they can affect your whole body.
And again, like, because people really don't talk about it. And I think I only heard of the term perimenopause, I promise you, in the last like 3 or 4 years, because a few people told me about that in the office. I know that we also did an Instagram live, which is, by the way, still available on my profile on Instagram if anyone wants to look at it. I know a lot of people have asked this. I know we've discussed this before. Can you delay menopause, or is there anything that makes menopause onset earlier for some people than others?
Yes. So if you smoke, you're likely to go through menopause on average a couple of years earlier than people who don't. We're not exactly sure why, but we know that smoking fills up your arteries, so maybe it fills up the blood supply to the ovaries as well. The average age of the menopause in studies is 51, but that is actually the average age of Caucasian women in the Northern Hemisphere. And we know that Black women are likely to go through a little bit earlier than that, and that you can have symptoms for up to a decade before. And there is some evidence around things like legumes might make a difference, about oils might make a difference, but actually we think it's mostly genetic, aside from the smoking, about when you are going to go through. And if you have a family history of a premature or an early menopause, then you're more likely to have an early menopause yourself. If we take out your womb, even though we've left the ovaries in, you also are likely to go through a slightly earlier menopause. But there is no medicine that I have to delay when you're going to run out of eggs. And so people say, well, I've got the pill, or I'm on the coil, or whatever. No, it might cover up the symptoms, but you're going to run out of eggs when you run out of eggs.
What about stress?
So stress can affect your menstrual cycle, but that isn't the same as affecting when you're going to go through the menopause. So I can turn off your menstrual cycle using medications. That doesn't mean that I'm saving those eggs for later. And that doesn't seem to work, which then begs the question, okay, if you have IVF and we stimulate loads of eggs in a month, does that mean you're going to have a menopause earlier? It doesn't seem to do that. Yes, we absolutely do need more research, but it comes back to the fact that about 1,000 eggs have the potential to mature each month, and maybe in IVF we're just making more of them mature than would naturally. But there is definitely harm related to smoking. We also know that people who do not exercise, who drink alcohol, who have obesity are going to have are more likely to have worse perimenopause symptoms when they come. But I think that what we need to do is change the mindset from, I must delay the menopause. Well, why do you want to delay it? Well, because I want to be young, and I want to have good skin, and I don't want to have symptoms, to, well, hang on. You can have all of those things and be happy and be well and be healthy after the menopause. Because on average, women in this country live about a third of their lives after the menopause, and that might change to half of your life after the menopause in 100 years' time. So actually, maybe we need to ask a different question, which is, how do I be well and healthy afterwards, as opposed to trying to put it off?
Yeah, I love that. And I think that's a really beautiful way to end it. I could talk to you about so many things. I think we're going to have to do a second episode with you, Philippa, because you are so wonderful. For those listening, could you please tell them the name of the book and where they can also get it?
So the book is called The Science of Menopause. It's published by Dorling Kindersley, and you can get it anywhere and everywhere, online and in bookshops. And I am on social media at Dr. Philippa Kaye.
Perfect. Thank you so much. This
Thanks
has been
for having me.
So lovely. And thank you for your honesty and vulnerability. She's an absolute force. So I recommend that you do follow her, because I've gained a plethora of knowledge from just following her, and, had the honor of also being in her presence. So thank you, guys. And don't forget to like and subscribe to my YouTube as well, so that you can get the long form videos. Okay. See you next time.
Bye.
Bye.